Welcome to another episode of What Brings You In Today.
I'm Erica Bennett.
And I'm Taylor Fisher.
And we want to thank you for tuning in and listening. If you are a fan, we'd like you to subscribe to the podcast to make sure you don't miss any episode. And also be sure to leave us a review.
Yes, and if you have any questions or topics you'd like to submit for us to talk about, you can do that at our website at sgmc.org/podcast.
And today's going to be a fun episode. If you'll notice, we have more people in the studio than we normally do. But we have Samuel Edusa, MD, and Anna Ledford, MD, and they are our internal medicine residents here at SGMC Health. So, doctors, what brings you in today? Go for it.
We are here to talk about internal medicine and the life of resident physicians, kind of our path to getting here, what all it entails.
Cool. All right. Well, let's get started. We'll start with you, Dr. Edusa. Tell us a little bit about your journey to become a doctor.
My journey. So my
Because
journey's
you have
been
an
pretty
interesting
long.
story.
Yeah, pretty interesting story. So I went to medical school in Ghana. So that's a country along the West African coast. 34 million people. I think that's about 3 times the size of Georgia.
Wow.
Yeah. So started there, went to medical school. Medical school there is about 6 years. So completed that. And then once you're done with medical school, you have like 2 years of, we call it housemanship. Mm-hmm. And that's kind of akin to, I would say, about a year of family medicine residency. So you go through that, and that you rotate through everything. So you do pediatrics, OB-GYN, you do internal medicine and surgery. Once you're done with that, you're fully baked, essentially. You're a full-fledged doctor. So then you assume the role of a medical officer. So after that, I worked in a couple of government hospitals, military hospital, other government hospitals for a couple of years. And so from there, my journey takes me here to the U.S., So I come over here and moved to Peachtree City, just south of Georgia with my wife, and was doing some research. Then I volunteered at a couple of hospitals as well, and needed to fend for myself, and the family. So I veered off a little. So my additional job was working in software. So I did the whole software engineering thing just to kind of, support the family. And yeah, just continued on that path and then took the medical license exams, 3 of them. I don't want to think about them. It's a lot of questions. But then did that and then, applied to residency and then got accepted at SGMC, and I've been happy ever since.
Awesome.
Yep.
All right, Dr. Ledford, I know you're a little closer to home.
Yes.
Tell us a little bit about your journey.
Yeah, so mine was kind of non-traditional, I guess you could say, as well. Was born and raised in Cleveland, Georgia, about an hour and a half northeast of Atlanta. Went to undergraduate school there, became a registered nurse, worked for a few years doing that, decided to go back to get my nurse practitioner degree, my master's degree. So attended Vanderbilt University in Nashville, did that, worked for a few years, alongside some great attendings that really encouraged me and kind of sparked an interest in learning more about the medical sciences and diving deeper into the care that we were providing and everything. So I decided, what better way to do that than to go back to medical school. So I attended a school in the Caribbean, did all of my clinical rotations, most of them in Northeast Georgia, a few in South Georgia, and then in Iowa also. Then came time for applications. I knew I wanted to stay in the state of Georgia to complete my residency training. So fell in love with South Georgia Medical Center when I interviewed here, and here we are.
Awesome.
Here we are.
We're glad to have both of you here.
Thank you.
And I love the non-traditional path because I took a non-traditional path with my education as well and started off in a technical college and then finished my bachelor's degree only 2 years ago after working for a while. So I love that, showing the people that it's possible even if you go a different way.
Yeah, that you're never stuck in one spot. You can always, have the opportunity to try something different. I mean, and it can be harder and more challenging if you have families or different dynamics and you're trying to also maintain revenue during that time.
Yeah.
How would you say, do you think, because I always wonder this as far as being a nurse first and then a MP, How has that prepared you for the medical schooling?
I think, so the exposure to, different aspects, you can kind of see, you have a different vantage point, I would say, a different view of it. You kind of get to see things, I worked as a medical assistant before I was a nurse. So, all the things that are going on sometimes kind of behind the scenes in the patient care. So it's a neat perspective. I also think it's really helped me communicate with my patients better. And the appreciation I have for our nurses, our techs, and everything has just been, I really appreciate that now. So I think it's helped me in those aspects. It was a little difficult, transitioning over from nurse practitioner to an MD because, our first year of medical school is very heavy on the medical sciences. So kind of transitioning from the nursing role, getting into that was a little difficult.
Yeah.
It's different, but thankfully, it all worked out and we're here. So,
And Dr.
Excellent.
Edusa, you have a lot of family members in the medical field, right?
Correct. So my mom, she's Ukrainian. So I'm half Ghanaian, half Ukrainian. She trains as a surgeon, and both my parents met in Kiev. That's Ukraine. My dad was an ENT specialist, but he passed away. And then my eldest brother, is a radio oncologist. Then I have my other brother in Connecticut who is OBGYN. So,
Did either of you kind of know you wanted to, what kind of drew you to medical field? Was it just seeing your family members do that, or do you just feel like passion to help people?
yeah, I think, go ahead.
I think it's both. I mean, if being in an environment where they speak about people and, like, not just patients, but like, hey, I met this person and he was sick and he got better. You just have that feeling that you also want to be in that position to help people. So I guess growing up in that environment, it almost seemed like a no-brainer, but then I tried to deviate and I came back to the path, because it's like one of those things, you go off the path and then you realize that, no, I really want to be doing this.
Yeah.
And then you kind of go back. So, yeah.
Yeah, I think that's, growing up, I had my grandfather and my grandmother were sick a lot. They had, chronic conditions that required them being in and out of the hospital. So I was exposed at a young age to medicine, So I didn't know exactly, when I started out, I really did not know in what capacity I wanted to be in the medical field, but I knew I wanted to do something in the field. So that's how I kind of got started as a nurse and then, transition over to
But so cool and important that you're following what you're feeling led to do.
Right.
That's right. Yeah.
That's cool. And I think that definitely makes the best kind of doctors because you really care. You're not just doing it because it's like a check box of something you want to accomplish.
Yeah.
So.
I agree.
Yeah, I think you have to have a heart for people and service if you're going to take care of people because it sometimes can be a thankless job, I think. And sometimes, it's, all the time probably very difficult dealing with that kind of pressure and, dealing with people's loved ones. You can feel, grief and heartache sometimes.
Yeah.
That's true.
So,
Yeah. It's not always, sometimes we don't have the outcomes that we hope for. And so those are tough times, and you have to be strong, be there for the families and everything. But then also we feel that with them, so it can be tough at times. Yeah. But
yeah.
very rewarding knowing that we're helping, the patients and their families.
Yeah, it's extremely gratifying.
Tell us about internal medicine because I really didn't know what that was until we started our program to learn what is internal medicine because it's kind of a lot of everything. But what drew you to internal medicine and what would the average person need to know about it?
So internal medicine, it's, kind of the name, internal, I get this question a lot of times. Our patients are like, I didn't even really know whenever I scheduled an appointment with you, what internal medicine is. So we take care of the whole body, and disease processes that can occur in the body. Typically, we see patients 18 years and older. So that is one thing that kind of differentiates us from family medicine per se. So we deal with a lot of disease processes, anything from cardiac issues to diabetes, kidney problems, things like that. So the neat thing, that's one of the things that drew me to internal medicine, was the exposure to all these different pathologies, and we get to kind of dabble in to each of the specialties. That's the neat thing. And as internal medicine residents, we get to rotate through most all of the specialties. So we're going through cardiology, neurology, nephrology, what
Like
am I
all the other
missing?
elective programs.
Yeah, endocrinology. So we get rheumatology. So we get exposure to kind of a little bit of everything, you know.
But that has to
so.
make it harder, right? You got to know a lot
No,
more.
it's true.
This is true, but those rotations, in my opinion, have been some of my favorites because it's helped me, you know, take little bits and pieces from each of them, bring them back to my practice either in the hospital or the outpatient setting, and be able to manage better, I feel like, you know, those conditions like diabetes and heart disease, things like that. A lot of our patients are followed by the specialist, but we're taking care of them, again, for their primary care needs. So I think it's real important to have a good knowledge of all of the, you know, the conditions and everything.
Because as we've seen, like when we've talked to all the specialists, everything interacts together.
It
Like
does.
everything
Everything
works
is linked.
together.
It really
Everything
does.
is
Or
linked.
impacts.
Yeah.
Yeah.
I think the other thing as well, just to add to Dr. Ledford, is it's in addition to the breadth, like a depth and like breadth of the field, it's like the longitudinal care. So like, I mean, I'll give you a classic example. Like I saw a patient in the ED, admitted the patient, took care of the patient, and it just so happened that my rotation was ending, so I was going to the clinic, and I saw the patient again. So I've kind of seen the full life, sort of life cycle,
Right.
essentially. Hopefully it doesn't come back to the ED, but, you know.
Yeah. Well, and that's nice because then it's that continuity of care.
You're able to
Right.
follow the person, throughout, and then hopefully at that point in time, you know, work on the prevention to prevent him from coming back. But, it just gives you that additional... it's nice to be able to see the
Relationship,
patient, that relationship.
So what does a typical day look like? I know you guys do all these different rotations and everything, but right now, I guess, what does a typical day look like for both of you?
You want to do clinic? I'll do inpatient.
That sounds good. Yeah.
Sure.
Yeah. Because
Okay.
it's very different, as you said, depending on kind of where you're at.
Rotation, yeah.
Tell us about inpatient.
Inpatient, I would say it's like a carefully choreographed dance without the movement, but it's more like patience and, you know, medical like knowledge. So I would say it begins, I'll just give you a typical day. I'm just using myself. So it begins maybe just, you know, before it gets light. So maybe around 5:30, you get up, then you come to the hospital. What I would do is you'd begin by like looking at the charts quickly, and then you'd go and see your patients. So you'd go speak to the nurses, you know, at the same time you'd like review the notes, what happened overnight, do all that prep, come back to your computer, and then at 7:00 we have the night team. That's the residents that come by, and then we would get like updates about what happened overnight from our patients, and then from that point onwards, we're like in the whole pre-rounding phase. So we're working with our seniors if you're an intern, and then basically building the plan before major rounds. And rounds involves like working with the attending who's with the team. So we'd round with the attending, the other team members, and we'd go from room to room, discuss the patient fully. So we'd go through all the conditions, and then that's where we do a lot of learning as well. Come up with the plans, and then just do all that. That would maybe take us to about 11:30, 11:45, depending on how long it takes. And then we have lunch, and then we have like a huge chunk, which is a didactic section. So that's when we, like listen to reports from other residents or interesting cases as well. Sometimes we have external speakers that would come and talk about, topics that are pertinent to patient care. We also have like sessions where we have like medical jeopardy. So it sounds fun, but it's also, very educative, because then we're going through a lot of trivia. And then times that we'd go to the simulation lab. I'm sure you've heard about the simulation lab that they recently inaugurated, And then there we would like go through like mock codes. So basically just practice what would happen if there was a code there. We'd have like scenarios. We also have like a POCUS station, which is point of care ultrasound. So we'd practice there as well. We can also like try like central lines, LP. So basically like a station where we perfect our like fine skills as well as like working in teams. We do all those. So a lot of heavy learning happens around that period of time. I mean, learning is all throughout,
Right.
but then that's like a chunk of time. And then we'll come back, finish up the plans, basically see if any patients need to be discharged, like do all that stuff. And then kind of, depending on if you're admitting or not, you'll be seeing new patients throughout the day. But then that would take you to about maybe 5, and then by 7, you would sign off again to the night team. Basically go through each list and say, hey, this patient needs to be followed up on this, focusing more on like the sick patients, the sickest on the list, just so when you kind of pass the baton on to the night team, they know what to do. And then the cycle continues.
Yeah.
And just for our listeners, I just want to, an intern is a first-year resident.
First-year resident, yeah.
And then a resident is, you've been to medical school, you're in your residency training, you're already a doctor.
Correct.
And then you're still training. And then an attending is like a senior physician.
So that's, someone that's completed residency
Completed
training.
residency.
Yes,
Yeah.
I kind of know these things, but
Right.
just for our listeners, in case
sure.
they weren't
Right,
sure what
right.
those terms meant.
Yes.
And the other thing too that we would like to point out to our listeners, because you're talking about caring for inpatients, and that's a trend too that's kind of changed relatively over the last decade, of where you had more physicians that just work in the hospital setting to see patients, so they're called hospitalists. But that are trained specifically to care for those patients while they're in the hospital. So you really got that skilled and techniques to deal with those specific patients, but also that you're working with like a team of people while you're in the hospital. It's not just one doctor, like you said. Having the educational aspect now here at SGMC Health, that it really elevates that level of care that patients can receive, because you have so many people, and you're having to explain everything. Correct. So that everyone understands,
And extra eyes on your
Exactly.
charts and your work and everything. So
just kind of wanted to share that aspect of it, because that's something that we haven't had until the past couple of years, but it's really important, and that's value that y'all add to our program. And then when you're done with your training, and then hopefully you stay here, and then you can potentially train some of our other ones.
Right.
So what about your day, Dr.
Yeah.
Ledford?
Yeah, so clinic day is a little bit different. Just depends on, again, kind of where you're at. I'll say all of the electives are very similar to a clinic day also. So, typically get up around 6:30, where we try to be there around 8 a.m. Don't start seeing patients usually till 8:30 or 9, but we are in that time, beforehand, answering any phone calls, responding to patient messages, reviewing labs that have came through from the prior day, things like that. And then also chart reviewing, so that we're ready for our patients when they start coming in 8:30 or 9 or so. So then we will see, as you start out on your intern year, you're typically going to see a few less patients in the morning time, and then in the afternoon time also. And then as you move into your second and third years, your patient load gets a little heavier. But we'll typically see patients from 8:30, 9ish to 12 or so. Usually our last patient's no later than 11 a.m. so that we have time to finish up, do our charting and everything, get our orders put in before we attend the noon conferences that Dr. Edusa was speaking about. So then we'll go to that. Those are our didactic sessions where, again, we have our academics and everything. And then after that, we'll typically come back to the clinic. Usually our first patient in the afternoon starts at like 1:30 or so, and then we'll go to 3:30 or 4. Then after that, we're just finishing up with notes, again, answering more messages, responding to lab results, things like that. We'll finish up our day around 5:30 and head home. So,
Are either of you leaning towards one or the other as far as what you want to do after you complete your residency, if you want to be in the hospital full-time or in a clinic?
yeah, I kind of want to do a little bit of both. I think I'm leaning more towards clinic at this time, but I do want to, augment with some hospitalist work as well. I think it's important, to to maintain those skills and everything like that. And also, I enjoy it. I like both. And, there are some physicians are still doing traditional medicine, where they're seeing their patients in the clinic, and then they're also admitting their own patients to the hospital, rounding on them, things like that. So, there's that also. But yeah, I think I want to do a mix right now. Yeah.
Mix as well. But I think it would lean more towards the hospital.
Yeah.
There's really nothing like working in a hospital, is there?
Yeah, I know. It's like
There's
I definitely
some
have
kind
to
of
have
energy.
that component. Yeah.
I'm the same.
Just walking around, I need to
I'm gonna
see,
need in whatever fashion that happens. I'm gonna need that. I feel
It's like the
so.
adrenaline rush of the unknown.
Exactly.
You never know. You have a lot more.
It's definitely
Energy,
different than any other job I've ever had. And I'm not a doctor.
Yeah.
It's fun. You never know what you're gonna get.
That's
You
right.
don't. So I think we could probably switch to talking more about medical and not just about residency, because you guys cover so many different things. So I know we probably see a lot of, we've talked about this, like diabetes and different things like that in this specific area. What do you guys see the most? What do you treat the most? And do you have any kind of like tips maybe to help those patients keep on top of those conditions, or when they should come in?
Right. Yeah, I think, like as we mentioned, I think diabetes, hypertension, we see a lot of heart failure patients, chronic kidney disease, COPD, things like that,
COPD as well.
asthma, so a lot of those chronic conditions. We also see acute stuff, too, in the clinic especially, and in the hospital also, acute conditions, pneumonias, urinary tract infections, things like that. So I think you had asked, how we can help to, our patients with these diseases and things like that. I think good follow-up, make sure you're following up with your primary doctor, any of your specialists that you're sent to, so that if anything's changing, we know about it before it gets to a point, where there's complications from your disease.
And make sure you have a primary care doctor.
Primary care doctor as well.
I think is the place to start that we always talk about,
Yes.
because even if you're well, it's still important to go to the doctor at least once a year, right?
Yes.
And can you talk a little bit about why that's important?
Sure.
So there's this whole misconception that if you're not sick, so I always say there's this misconception that you have no symptoms equals no problem, but it's actually not true. Because a lot of these diseases like hypertension, diabetes, they basically run under the radar, and they won't really manifest until it's later on. So it's really important to go to your primary care or find a primary care provider so that they can start the workup, or, you could even just go there for a rash and then they check your blood pressure and realize that you have elevated blood pressure. But at that point in time, we could put in the measures like start you on a medication, start counseling on diet, exercise, lifestyle modifications that could kind of mitigate the complications. Because ultimately, you don't want to get to the end there. I mean, what we do is when we see people in the ED, we're managing complications at that point in time. So we try and stabilize the condition, and then they follow up with the primary care provider, and then
But
we
sometimes
can
they
kind
don't,
of,
and then
don't.
they are
Exactly.
repeat.
They fall off, and then it comes back again.
Yes.
And then
So-
generally speaking, a lot of these conditions, when you get to the point where you're having symptoms, they've progressed,
Right.
and as Dr. Edusa said, a lot of them, are asymptomatic whenever this condition starts, but by the time you get to the point where you're having symptoms, it's often, advanced disease at that point.
And if you have no baseline for when you're well, when you
Correct.
do start to get sick, even if it's not, crazy, then you kind of, it's hard to tell, is this how you normally are, or,
And I think this is kind of off topic from the internal medicine, probably is more of the emergency medicine, but I think a lot of people think that, they struggle with something and then they go to the emergency room, and it may not be a true emergency per se, probably something that should be managed by a primary care doctor. And then they get to the emergency room and the emergency doctor runs whatever test and said, oh, well, no, you're okay. You can go home. But they didn't really solve their problem, because
Right.
their goal is to just make sure that you're not experiencing something life-threatening,
Life-threatening,
and then get
correct.
you home. And then for you to follow up with your PCP. So a lot of times people get upset that they don't feel like the ER physician like did what they needed, but that's not the job of the
Correct.
ER. I mean, even though they will try obviously
Right.
to help in any way they can, but ultimately you want to go to a primary care physician for that. The ER is for that. I mean, if you're not,
Life-threatening.
yes, their job is to save you,
Stabilize
you. Yes, and if it's something that is better fit for primary care, then that needs to be taken care of in that level. Again, most of the time, I guess, because you need to follow up with them consistently to make sure whatever you're doing is working. But that's something I've heard from a lot of patients, and that I think is a misconception of that the ER is also like a primary care doctor,
Right,
but
definitely.
they don't serve that role.
But the urgent care is primary care because, you know, they just go repeatedly. And I think we are trying to encourage people to see the primary care for, because urgent care, obviously, you can't help that. You know, you need something
That's true.
right away.
Right.
It's Saturday. That's a great time to go to urgent care.
Absolutely.
But you could also make an appointment if it's not super emergent and then go to your primary care doctor and then have a relationship with them
Build
and
a
see the same
relationship and a
person
rapport.
every
Yeah.
time.
And that's one thing too about our internal medicine residency clinic. We always try to leave, you know, a little space where, in the mornings especially, you know, if we have a patient of ours that's sick or you know something it has acutely came up, you know, we can always try to work them in, you know, get them in to be seen, so that it doesn't, you know, progress to them
Right.
having to go.
But
to
you
the
have to have
emergency
that
department.
relationship
Absolutely,
Right.
to be able to work them in, or else you're like, I don't know this person. I don't know what's
That's
going on
right.
with them. I don't know how much time I need.
Exactly.
So the best time to get a primary care provider is when you're feeling well, so that
Exactly.
you can have time for them to get you in, and then when you see them, you are feeling that better. You know, you can get that baseline accounted for, and then when something happens, then you've
When you're
got
doing your
partner.
whole new
Right.
year, new me,
Go ahead and schedule your appointment.
schedule it
Go-
now for
Yes.
January.
Yeah.
Go ahead
Yes.
and get on the books.
It's like your car tune-up.
Yes.
You take it
Yes.
for regular maintenance.
There
you don't
you
wait
go.
for it to break down. And then you don't have a
Exactly.
car.
Treat yourself better than your car.
Yeah. So it's very, very important. Treat yourself better than the car. That's a good thing. And I always say healthcare, it's a journey. It's not a destination. So we are here just to guide. I mean, ultimately, as we all say, even in our medical training, the patient is the best textbook. You know, we learn whatever we learn, like we go learn all these things, but then when you sit down, it's personalized care. Every patient is unique, every patient is different, and we learn from the patient. So we're both in this journey just to guide, learn from you. We educate as well, you educate us, and then we know we're on this journey together.
And that's kind of, you know, to piggyback off of what you just said, you know, you learn so much just from talking to the
Right.
patients, you know, just, you know, look away from your computer, put your pen down for a second and just listen, you know, and they'll tell you so much about, you know, and a lot of times you've already got things in your mind, you know, you're thinking as you're talking to them, you know, of what could be going on, you know, and things like that. So really, you know, you just learn so much from them, you know.
Is it sometimes things that they don't tell you that you learn from? Like, I know there's always like the hand on the door kind of, what do they call that? Kind of a last minute question or something they ask, or you can tell when they're hesitating. And you know that if you work with that patient over a long period of time.
Correct.
Yeah, I've had several of those instances where I'm just like, you know, I'm kind of stuck. I'm like, I don't really know, you know, what's going on. And then, as you said, we're kind of walking out the door, you know, and they'll bring up one more thing, and it just like it's the last piece of the puzzle, and I'm like, oh, okay, yeah, you know, and then it's so clear, you know, what might be going on. So
Do you have tips for patients? Like, is it recommended that they write down their questions ahead of time?
Absolutely.
Anything else? I mean, because it can be intimidating going to the doctor, and a lot of times you'll forget.
Or you get anxious and then you
what
forget.
you're gonna,
Right,
like
yeah.
something that was important, and then you get home and you're like, crap, I forgot to.
Yeah, a lot
Yeah.
of people, you know, I always tell patients, you know, white coat syndrome's real. You get in there, it's especially if it's your first visit. You know, you're just meeting us, we're just meeting you. You know, they're asking you all these questions. You're having to fill out the forms and everything. So, you know, it's you tend to forget, like you said. You know, if you did have any questions, so I think that's very important. Write down any questions, you know, before the visit. I always encourage folks to bring a list of their medications with them. Anything else you can think of, Dr. Edusa, that...
I mean, if you can come with like a a loved one or family member as well. That
Absolutely.
also kind of helps ease, the agitation
level,
or
yeah.
comfort level as well. That's also.
That's a good too, especially if you're going over like results or things like that. Just having somebody
Like a
with
support
you.
person as well, just helpful.
Exactly, yeah, and they can help you kind of remember. You may have forgotten, oh, what did they say about that, and then they might have retained that. So I think
Yeah,
that's a
and
great
spouses
idea.
can typically remember what ails their other spouse,
Exactly.
They might not be telling you, but they're
Yes,
like, oh, you
I-
forgot.
Right.
You
I
forgot
have
about
someone
this.
in my life. Yes, I have someone in my life, and it's not necessarily my husband, but
Okay.
this person does get anxious at the doctor. And when you ask, hey, what did the doctor say? They don't remember.
Right.
So it does help to be able to go or, have that MyChart proxy
I was gonna
access
say
if they
that.
give you
That's-
that.
Oh, that's true.
That's
That's true.
well, even for the patient to having that MyChart, because you can go back and look and review what you told the doctor, what the
Right.
doctor said. So that's so nice. To just a good tool to have to keep you, and then it also helps
Absolutely.
remind you of your upcoming appointments, so you can
Yes.
make sure that you're attending those. But
Yes.
definitely, we've come a long way
Yeah.
in tools for patients to help keep themselves accountable and help them live healthier lives.
I think we're almost at our time, but I did want to ask what your favorite part of living in South Georgia is. I know you're a Georgian, but South Georgia is a little bit different than North Georgia.
It is,
So,
yeah.
do you guys have any favorite parts?
Yeah. So, the Southern hospitality. Two things that I really loved about South Georgia. The further south you go, the hospitality just gets better and better. So it's amazing down here. Everyone's super friendly. And the other thing is I love the landscape. Just riding around, seeing all the farms. Just beautiful scenery here. So those are probably my two favorite parts about South Georgia.
I would say the pace. I really like the pace. It's nice and chill. I mean, I was in Atlanta before. It's hectic.
Yeah.
Even getting out from your house to drop off the kid at school, you have to leave at 5:30, and it's like 45 minutes for like a 5-minute walk. It's ridiculous. So, but it's really, really nice. It's almost a little laid back. I mean, we finished. It's still hectic, but then, like for instance, recently we got into pickleball, which has been amazing. So just to be able to do that, and the weather permitting as well. So the
Yeah.
weather is great. So
Well,
for
now
me,
they
it's
have
similar
indoor
to-
pickleball, so you don't even have to worry about the weather.
Yeah, we're trying to get into that too. We're trying to start a league, so
Yes.
maybe we'll do the whole.
Oh, and I have to ask about the
Indoor.
cafeteria.
Oh no.
So, sorry, one more question. We try to ask our guests what your favorite meal is in the Spice or in the cafeteria, since you guys eat here and stay here
You're here
so
a lot.
much.
Yeah.
I like the bowls.
The bowls.
The bowls, yeah. So I like that salad with the salmon. I'm a big fan of salmon,
Yeah, me too.
and I like the shrimp bowl as well. So I'm a big fan of the bowls. So that's the
Yeah.
other section, which is the
Yeah.
healthier side.
Those are good.
Yeah, I like
What
the
about you?
not
I like
so
the
healthy
chicken,
side. Chicken tenders.
Chicken too, though. Yeah.
Are amazing. The mac and cheese.
I can tell you're a Georgia girl.
Yes, and
Mac
then
and
the
cheese.
scrambler in the mornings.
Oh yeah.
That was my favorite part of nights was getting off and going to get the scrambler.
We have a good breakfast in the Spice.
It's really good, yeah. And for those that don't know what the scrambler is, it's like eggs and bacon and then like some potato wedges on the side. It's really good.
And does it
So-
put the sauteed onions in the
You can get
peppers?
that. Yeah, and some cheese on it. I usually do pepper jack on it. It's really good.
Now we're all good and hungry
Yeah.
before lunch.
Time for lunch.
It's always fun because our food services take good care of us.
They do. They do.
So I appreciate them.
Well, thank you guys for joining us today.
Thank
This has
you.
been a
Thank
really
you so
fun
much for
conversation.
having us. Yes.
And thank you to everyone for listening. Please like and subscribe, leave us a review, and submit your questions at sgmc.org/podcast.
All right. Everybody have a great day.